Thank you. I would like to call Dr. Seetharaman to talk about management of traumatic brain injury.
Afternoon to each and every one of there are a lot of distinguished dignitaries, and it gives me immense pleasure to present the management of traumatic brain injury at the Bombay Psychiatric Society clinical meet. So here we go. Initially we would go ahead with various prevention strategies that are possible, and prevention is the key. So strengthening existing laws would benefit, and also creating awareness amongst public is something which needs to be done at a larger scale. There are various initiatives, and these needs to be emboldened even further, wherein neuro care in terms of especially trauma is dedicated centers needs to be established. There is also this initiative called as Gunapati Venkata Krishna initiative, and this has been covering many states across our country, and it basically transports the patient within 2 hours of the injury or the accident. And finally, to reduce the tertiary care burden, the trauma care at the local or regional centers needs to be made better. Next slide. And going forward, we can see the challenges that can be faced in terms of the cognitive rehabilitation. So the nature of TBI, we have seen a lot of wonderful cases, and many cases highlighted how the nature of the TBI can have different presentations. Again, expanding research in the sense that the research in terms of the total literature available in traumatic brain injury in India is very scarce. So there is a lot of expanding research even currently, and the impact on daily life will also obviously affect the patient outcome, because there are many patients who are not able to participate in the rehabilitation because of the neuropsychiatric components. And also in terms of the inadequate resources, that's a big problem. Awareness, again we spoke about that there is inadequate awareness and poor liaison. So generally these patients are referred to us either from neurosurgeons or neurology department, and once the management is begun, and I feel that there are a lot of institutes where the liaison is also lacking. So that's also an important challenge when it comes to cognitive. Moving forward, for various assessment protocols that needs to be done. So in terms of the assessment protocols, initially we need to rule out whether there are comorbid or pre-existing, rather I should say, neurological, medical or psychiatric conditions. So, and apart from that, we have to also make sure that there aren't any contributing factors for the cognitive impairment. And the contributing factors per se can be medications. It can be drugs like first generation antipsychotics or sedatives or pain, a lot of medications for pain. And apart from that, there can be hearing impairment or any other problems which may contribute to the cognitive impairment. And again, we need to see what else can be done in terms of the protocol. So blood investigations must do, MRI must do, and neuropsychological testing, as we seen in most of the cases that we have. Now I would like to present a tool developed by Dr. Dino Chaco from GMC Ernakulam. Her team has basically presented this at ANSEPS, for which she received the award as well. And this is a tool to basically measure the disability as well in terms of the neuropsychiatric components of TBI. And it has not been published, and she was kind enough to share this with us so that we can present this and show how much of initiative has been taken in this particular field. And the next slide is also similar, like wherein it encompasses the similar tool, and this we specifically wanted to share with all of who have come today. Slide 7. So what are the principles of cognitive rehabilitation? So first, functional oriented cognitive modules. It should not happen that a patient is given a cognitive rehabilitation which is out of his ability. So pre-trauma cognitive abilities and the functional needs in the future needs to be mentioned. And also compensatory strategies. It can be external or internal, which we will dwell into when we come to the individual domains. Modifying the environment is also an important principle which needs to be done, integrating a lot of strategies so that there is generalization of skills, and group initiatives is a must for many patients in whom individual intervention is not possible. And also reassessment from time to time is the need of the hour, because we would not come to know how much of an improvement the patient is having. And finally, last but definitely not the least, would be that training and psychoeducation of all caregivers and stakeholders involved. Moving forward, we would now look at the latest guidelines issued by the Indian Psychiatric Society in terms of trauma, traumatic brain injury and neuropsychiatric manifestations and their management overall. This is as recent as January 2025, and we made it a point that we should share this with everyone today. So the first algorithm that we have is a general assessment of what has to be done. So initially, as we mentioned earlier, we would be dividing the patients based on the severity, which can be done either on the GCS score or some other parameters. Once it's mild, then it's symptomatic management and conservative management most often than not. But if it's moderate or severe, then what needs to be done? So we need to initially first rule out whether the patient is in coma or vegetative state. And once we rule out that the patient is not in coma or any vegetative state, then we need to see and screen for PTA. PTA is post-traumatic amnesia. And once PTA, imagine that the patient has PTA. Even in that situation, you need to see whether the patient has confusion or not confusion. If the patient doesn't have confusion in the state, then it's very easy that you need to manage the you need to reorient the patient, provide reassurance, provide sleep, and make sure that there is minimal environmental stimulation. But imagine that the confusion is present for the patient with PTA, then non-pharmacological management is still the first line. However, if push comes to shove, then we can start low and go slow with antipsychotics. And if the PTA is not present at all, then cognitive remediation in the sense of individual domains of attention and executive functions needs to be done. The next algorithm is for attention. So again, for attention, we first need to divide it into severity, rule out the medical or physical comorbidities if present, check for the motivation, and if it's mild or moderate, then metacognitive strategies can be employed. But if it is severe, then a lot of environmental modification along with dual task strategy and specific strategies can be put across. And if there is impairment in the information processing altogether, then methylphenidate up to 6 weeks can be given. Algorithm for memory is next, and this is similar to the one which we did for attention. Again, we would divide it into severity. This just for the sake of our people who might have dozed off. So this is similar to how we would manage Gajini if he comes to our OPD. So if he's severe, then we need to provide a lot of strategies in terms of compensatory strategies, external or internal, and also at the same time we would assess for the gender, comorbidities, the functional needs and the preferences. Select the appropriate strategy, whether it's external or internal, and also decide whether it's group or individual initiative. And if it's moderate, then again we have three options. The external compensatory strategies would include like a whiteboard or perhaps technological devices or smart books. So in that way, those things can be done. If it's internal compensatory strategies, it would involve metacognitive strategies and visualization. And definitely the thing which is upcoming is computer cognitive training. And we also finally would like to dwell into the complementary treatment strategies. So hyperbaric oxygen, as seen in case 1 presented by Dr. Sakshi, it works well, and it helps in reducing the overall inflammation. They're very much practiced. TDCS is not that practiced these days. It's a place of research in which people are using it more often in this particular field, but not as often as hyperbaric oxygen. Again, music therapy is something of my personal interest, and again, apart from that, we also have various apps, applications and mobile devices through which we can use and help patients in the future. So speaking of, we spoke a lot of non-pharmacological managements. Coming to our pharmacological managements. So in terms of individual disease disorders, so if you see there is depression post TBI, then the general doses which are mentioned is sertraline up to 150, citalopram up to 40, escitalopram up to 20. Then again, if it is mania, then quetiapine up to 200 can be given. And if it is PTSD, then sertraline up to 150 and paroxetine up to 50. And psychosis, so psychosis, risperidone up to 4 and quetiapine up to 750. Clozapine, our very own Brahmastra, so the doses which is mentioned is around 700, 750, but it needs to be made sure that a big amount of caution is exercised, especially when we go higher on the doses, because the ability of the patient or the potentiation for seizures in TBI patients would be much more than general patients. So that needs to be taken care of, and lurasidone up to 80 mg. Moving forward, for apathy and for inattention, for both methylphenidate can be given. Again, for other things like memory, again donepezil up to 10 mg or memantine up to 20 mg. And again, for other conditions like insomnia, zolpidem up to 5 or 10 mg can be given. Executive functions, again memantine or amantadine can be tried. And for other conditions perhaps which are not mentioned in the table, there are a lot of off-label users which use other antipsychotics as well. Since we also spoke about a lot of glutamate toxicity, just a small intervention in terms of what are the agents currently available in terms of the NMDA antagonists. So around 47 studies have been done, out of which 20 have been RCTs, and the maximum studies have been done on amantadine, 32, followed by memantine and the other medications. And we would like to see that memantine is the one drug which we have exploited it, frankly. We have used it extensively and we have had very good results. So the last slide would be about how the particular molecule works in general. So when there is NMDA toxicity which is present, then that eventually leads to tau phosphorylation, and the final outcome is that cortical spreading depolarization takes place. And memantine, the wonderful molecule that it is, it works by basically inhibiting the cortical spreading depolarization. It also reduces the pro-inflammatory cytokines, and finally it inhibits the expression of matrix metalloproteinase 9. Thank you so much for your wonderful time, each and every one of you.